Good morning, afternoon, evening, depending on where you are. My name is Jane Newman, and welcome to our talk about how we approached a website design pilot for VA hospitals and healthcare facilities. So before we get started, I'm going to let Kevin, my colleague, introduce himself. Go ahead, Kevin, you there?
Yep. Hey, folks. Kevin Walsh, work with Civic Actions. We're going to be talking about mainly our contract last year when we were working when I was serving in a role of content strategy and site builder, and I'm the product manager, or one of two product managers on this product moving forward. And yeah, talk back to you, Jane.
Yeah. So I was a content strategist last year, working with the team as well. We'll be talking about a few approaches that we took to plan and deliver this work. But before we get started, we'd love to know who you are. So if you could go into the Zoom chat and do this quick poll. Was there a poll? I think it's a poll.
No poll, just type it into the chat. We'd love to know kind of what hats you wear and if kind of a yes or no if you have experience in healthcare or VA.
And we'll give that about a minute just so that we can see some of the responses roll in. We know that there are 20 people in the room, so.
So a number of you may have already seen two other presentations from members of our team at this channel. Both are great. I encourage you to check out the YouTube recordings, which are being made available shortly, I'm pretty sure. We're going to try not to overlap too much. In some ways, we have the advantage of going last, and that allows us to do a bit of a deeper dive in a couple of areas. So in particular, we're going to be looking at the primary value proposition of VHA, which is the health services that are delivered. And we'll be looking mainly at the content side of that. So content research, taxonomy, modeling, the design of that content, and the operations and governance and editorial experience associated with managing it. We're also going to touch on some of the human-centered design techniques that we use both for CMS users and for veterans in determining how this content was designed and how it was presented and its IA and so on. But first, a bit of background about VA for those who are not aware. Second largest US agency, almost 400,000 employees, almost 20 million vets. There are 3 administrations, of which VHA is by far the largest in terms of any way of measuring it. It's actually the largest integrated healthcare system in the US, so it's kind of proof that public sector healthcare is possible at scale, even in the United States. And a little bit more background, and I think Robbie covered this morning, but so I'll glance over it. The VA's Office of Information Technology has been undertaking this digital modernization effort for, I think, the last 7 years. First big milestone was when VA.gov was launched in 2015. I think they learned a lot from that, and some people who are in the session were there for that. It was the first to bring a kind of a vet-centric, plain language and agile approach to VA, or the biggest effort for that anyway. The learnings for that were from that MVP were folded back into VA.gov in fall of 2018, and that's when the Drupal CMS team came to the project. We quickly became the source of truth for the flagship benefits content that had been kind of like the MVP for which was vets.gov, and then so that was, I think, spring of 2019, and then earlier this year we launched the VA Pittsburgh Health Care pilot website, which is pilot for 150 healthcare systems. And this is a big milestone because this is taking some of the approaches to content that had been done through vets.gov and the flagship content of VA.gov, and scaling it across VA in a much greater way. So it's not just digital service experts and contractors and high-powered stakeholders that were managing this content, but this is kind of extending that modernization effort across the country to hundreds of editors. So a bit about the scope and timeline. First of all, the pilot, each VAMC system, so VAMC is VA Medical Center, each system has a number of clinics. usually 1 or 2 hospitals, and then a number of community clinics or outpatient clinics. So this is the Pittsburgh VAMC system. There's 7 actual facilities within it. They offer 60 health services to vets. They've got a half dozen really industry-leading research programs, world-class institutions researching in areas of mental health and others. At this particular system, there's 3 or 4 editors right now that are managing this content. And yeah, a little bit about the timeline in more detail. The pilot was identified back at the end of 2018. Beginning of 2019, we started research design and development, launched soft launch at the end of last year, and then, as I mentioned earlier, in the spring we did a hard launch. Soft launch involved kind of both the legacy site and the new site were up simultaneously, and then the hard launch, everything was redirected to the new experience. So this was the first of 20 VAMC websites to launch. Websites is a confusing term. This is all within one website now, but they've always been thought of as separate websites. And there's 130 more of these VAMC systems that will be launching, plus other facilities, VHA facilities, in next year. A couple of points about our process. This is a VA spin on the USDS slogan of designing with, not for users. So, we talked to a lot of users of VHA services, much of it sitting here in the lobby of the main hospital in Pittsburgh. Our team performed in-person or remote moderated research sessions with 76 vets, veterans, family members, caregivers, and patient advocates. We also did remote unmoderated research sessions with 814 veterans, mainly card sorts and tree tests, and we'll get to that a little bit later on in the session when we talk about the information architecture. We also took human-centered design to our approach working with editors. So we spent a lot of time on the ground in Pittsburgh talking with stakeholders and editors, learning about their jobs, where they sat. So I think we did 38 sessions with folks about everything from form design, how to name content types, dashboards, workflow, editorial workflow. All of that in kind of a broader context of all the stuff that happens sort of offline, answering the phone from a stakeholder at the hospital saying, hey, I need a news release about this, and watching how they handle those requests. And I think one thing that's really important about these editors so far is that they are largely public affairs officers and their staff. So they kind of come from a PR and marketing and journalist background more than like a healthcare and health services background typically, although there's certainly quite a bit of diversity there as well. So we're talking about balancing kind of 2 different user groups. And I think this is the case for all Drupal sites, especially large ones where you need to worry about your editor experience as well as your end user experience. If the editors don't have a good experience, the end users do not. So this slogan was what we've come up with for our team: editor-centered management for veteran-centered content. I'll pass it over to Jane now. She's going to talk a little bit more about veteran-centered content and how this played out with the health services.
Yep. So I'm going to back up a bit and talk about content strategy approaches that we led before we went to Pittsburgh. So we started the effort with veteran-centric content principles in mind, and these come from USDS's approach to create a customer or veteran-centered experience driven by the USDS mantra, design with vets, not for them. So we wanted to translate this experience to the medical facility websites. So we had a goal of better managing distributed content and the publishing process across the over 150 or so separate facility websites. This approach was also informed by human-centered design research that was conducted by VA's Veterans Experience Office. So this is an office out of the central office, VA.gov. And they, over the past 4 or 5 years, have developed a design framework for the patient journey at VA medical facilities. So we also sought to translate some of these key principles into our website design. And so a few of the key themes that really emerged from the patient experience journey work were kind of make it simple, make it relevant, help me, and a big and a key customer experience driver around VA as an organization is trust. So earn my trust. So we really wanted to make the case for taking these principles and then translating them into, how we, developed content and experiences on these websites. All right, so here we go. So this is a map of VA hospitals across the country. So it's a big job to have to apply a set of principles across such a large and decentralized organization. So let me just give you an idea of the scale of VA. This map displays VA hospitals, which are the blue triangles, the larger blue triangles, and VA clinics, which are the smaller red triangles. And so this is the continental US. They're also in Hawaii and Guam and a couple of other territories. So the bottom line is that the footprint is huge. The Veterans Health Administration is the largest integrated healthcare system in the United States. It provides care at over 1,200 healthcare facilities and includes over 170 VA medical centers and over 1,000 clinics of varying complexity. In total, the Veterans Administration employs over 370,000 people. The Veterans Health Administration employs most of those people, so it's over 320,000 employees and over 9 million veterans. And they provide care to over 9 million veterans who are enrolled in VHA healthcare. Next slide. So this is an ancient VA saying. If you've seen one VA, you have seen one VA. And so while all of these facilities are part of an enormous system, each VA health system and facilities have their own unique characteristics. This translates to physical environments, the diversity of programs and offerings across each facility, the histories of all of these organizations or the facilities, the organizational cultures across these regions and facilities, the way communities engage with these VA hospitals depending on where they are. And the food is kind of different across these facilities, especially at the hospitals. And also how each facility might staff their digital communications teams and populate their pages and their websites with the content that represents all of these differences. Next slide. So this is just a smattering of a few hospitals across the country that I've had the privilege to be able to visit. And you can see how different they all look. Some are modern, some are in kind of older buildings. If you look at the San Francisco, California VA, that's like an Art Deco building, kind of right on the ocean, on the Pacific Ocean. They're in this unbelievable plot of land. But there's a big difference in just the physical footprint of each building. So before we embarked on the Pittsburgh MVP, it was really important for us to understand the similarities and differences across all of the VA facility websites. So we conducted a high-level review of all of these facility websites to understand current state and the publishing process for all VHA facilities. Next slide. So with a high-level content audit of the facility websites, we were able to find the good news, the strengths, is that facilities are really able to produce a lot of high-quality content in all kinds of formats. And there's a large volume of content that's available on all of the VA properties. So now, the challenges. What we found were that static pages are lacking structure and are not optimized for mobile devices. There is redundant content spread across a myriad of digital properties. So production and assets are siloed. The content is organized by administration. And there, I think for me, kind of the most, I don't know, sort of resounding message that I saw kind of across all of the facility websites was that there was no kind of common, the VA, the healthcare facilities offer health services across the board consistently, but there was no common taxonomy that was organized around those health services. And this was really a tangible opportunity to create some standardization across facilities, and I'll show you how we went about it. Next slide. So, how did we learn this? So to get an idea of how services are named and described at each VA facility, we did a deeper dive and looked at the services pages on each facility website. So this is just a screenshot of what a services page looks like. So this is just the Portland VA Health System. And so these services pages are required for each facility, but how they are populated is up to the facility to figure out. So they can manually control these, they name the services, and they describe these services. And so, and each facility can populate these services with unique names and descriptions. Next slide. So this is, so we ended up going through 154. This is 100, and I think this is 144 because I couldn't get them all to fit. So we did 154, we reviewed 154 services lists for the 154 facilities. And here is a tiny piece of what we found. Next slide. So if you look at this services list, this is just for 3 facilities. And so I'm gonna ask the crowd who's here, so these are the services lists. And what I'd like you to guess is across all of these facilities, how many services have the same name? And so if you can throw it into the Zoom chat and venture to guess, and don't look too closely at the lists, I'll give you a minute to offer a guess. Okay, so I'm seeing, we've got 3%, 0, 10, 10, 10%, 3, 17, 7. All right. So if you go to the next slide, I will tell you the answer. It is 1. So just for Buffalo, San Francisco, and Portland, the only service that has the same name across these facilities is pharmacy. You know, we didn't do this for 154. I think it would have driven us all crazy. But I think the message is that there's just a lot of disparity in how these services are named and how they're described. So as we kind of moved forward and we actually kind of did the work of consolidating the unique list of services, this is what we found. So while the actual services at the VA facilities are similar, they're named differently depending on who's responsible for naming them at the facility publishing level. So when we dug deeper and did the services inventory, this is what we found. There were 2,000 unique services names across these directory pages. So we ended up taking those 2,000 and we pared them down to get them down to just the health services that are offered at VA, because the VA facilities actually offer all sorts of other services, like there's a library, you know, sort of the canteen is a service, but we actually took those out because we really wanted to focus on the health services that veterans use. And, you know, you can go to the VA hospital for the cafeteria, but you're usually go if the reason that you're going is for a cardiology appointment. So we really wanted to kind of get down to the clinical services because those were the ones where we really wanted to find the commonalities. So we pared them down to a list of 1,200 separate names. So these were the names that were used across the system, but you probably know that in the real world, there are not 1,200 different health services. So we knew that we needed to consolidate the services that were the same but had different names. But before we, yeah, sorry about that. I'm kind of not tracking here. That had different names. And so what this told us too was that there was little convention or consistency in naming and terminology. There was a lack of consistency in how services are named, and that was creating a lot of confusion across the system. And then again, it's difficult to reuse descriptive content about services across the ecosystem and cross-link it to places. because things were just being duplicated and there was a lot of disparity in those duplications. Next slide. So there were a couple other things that we wanted to kind of gate check a little bit. So while we got it down to that, you know, those 1,200 services that we were planning on consolidating, we also wanted to know how VHA organizes its clinical services internally. So we looked at a few internal taxonomies. And we did this really to build credibility with the business so that they kind of understood that we kind of knew what was going on the inside. So we looked at these internal programs and processes. So I just have kind of 4 examples that are spelled out here. Treating specialties, again, these are VHA definitions around specialties that kind of the VA enterprise, you know, calls their treating specialties, and there were about 85 of those. Specialty care services, which are kind of subspecialty care, kind of services that are offered at VA. There are about, how many of those were there? 20 of those. And then we also looked at the clinical encounter codes, which basically tell you the clinic that a veteran goes to for their care. There were about 297 of those. And then we also looked from the VBA side, these what are called these disability benefits questionnaires, which classify service-connected medical disabilities kind of by condition. And there are about 69 of those. So those numbers meant something to us because they kind of, they're telling us that, you know, these are the number of specialties that are seen inside the business. So we knew we had to get it down from 1,200. And we wanted to be more in line with the numbers that were here. Next slide. Again, of course, you know, with 320,000 employees, there are going to be all sorts of other external facing taxonomy. So these, again, this is just an example which just calls out, again, the disparity in kind of how things are named. So there are a couple of other tools across VA websites that call out medical specialties, services at the facilities, how the specialty care services folks describe their services to the public, and then what's in the medical benefits package. But again, the message here is very little just consistency in naming. So everything in green is named the same across the enterprise. Everything that is connected by a red line is the same service, but it has a different name. And so this just, you know, kind of goes to show you that we're still, you know, we don't really have tight classifications across the enterprise. Next slide. So based on that discovery work, we came up with this taxonomy of veteran-facing health services or clinical services. And so we got this down to about 90. I think we're at 90. I think there have been a couple of iterations of this since. But we took these services, which were really meant to be put in front of veterans, and we developed a plain language description of these services to be used consistently across the enterprise. You know, we were really able to, you know, kind of hone down from that list of 1,200 and get it down to 90. And we have plans for this taxonomy to really be able to weave together the clinical services across all of the VHA facilities. And so I'm going to pass it back to Kevin to talk about how this work was put into practice at Pittsburgh.
Okay, so here again are some of the principles that we're trying to put into practice, and I'll talk a little bit about how we did that and what this actually kind of looks like. So here's a before and after. I'm not sure how big it appears on your screens, but the before is actually live still. It's pulled from Philadelphia Healthcare, which is still live, and it's the legacy. It's going to be relaunched in the next month or two, and along the lines of what you're seeing on the right, which is pulled from Pittsburgh Healthcare. And so just a couple things to point out. Excuse me. The plain language definitions of these services that Jane was talking about are right up here at the top. I'm out of order here, actually. Okay, so a few things to note about this. First of all, the new design uses US Web Design System. No big surprise there for most people on the call, probably. Some of you might bristle at the sight of the accordion, which is something that we could talk about, and we did a lot of debate and research around. And I don't think we're at the end of that story yet, but that might be a talk for another time. Second, it doesn't bury the lead. So the list of common conditions in the plain language text that Jane was talking about are right up front there. They help the veteran see that this health service is for them, essentially, because it does have the common conditions and description that is written in sort of a second person speaking right to them. And specifically with this example for mental health care, VA's actually done quite a bit of research on what language to use and what is the most effective language to use for vets. Fourth and finally, by the time this content design gets rolled out to all 1,200 VHA facilities, there's going to be 10,000s of these accordions basically across these facility websites, because each location that offers a service gets its own description of that service. And so that kind of begs the question, how to manage this single source of truth, this taxonomy for the 90 health services, while allowing for the diverse needs of all these facilities and all of the different individual service delivery points where these are available. So I'm going to talk a little bit about how we solve that problem. And to step back a little bit from the VA, I think this is the way of asking it. How do you implement an enterprise content operations and governance for kind of consistent but also localized content? And here's one way of doing it. So first of all, a good content model that can scale. I'll talk about that a little bit. Secondly, a simple but hopefully powerful enough enterprise-ready set of governance tools. And then thirdly, an editorial experience designed to support that content model. And the top task of editors is and the governance tools. So I'm going to go through each of those. This is a high-level view of the content model. I've got a link later on to our Drupal spec tool, which has all the content types and so on in it, so you can get more details. But I've provided it here to give a sense of scale, essentially. So in the Pittsburgh pilot, which is on the left, I've got some numbers these are essentially nodes. This thing over here are taxonomy terms. The round things are basically nodes. And so you've got, this healthcare system, which is this big thing here, 7 facilities. And then this health system offers 80 out of the 90 VHA health services. And that when you kind of multiply 80 by 7, it's not a full multiplication because not every facility offers every health service, you get about 200 individual health service descriptions. So that's the highly localized content that describes, we'll get into more detail in a second what's in there, but and once we scale this out to 150 more healthcare systems, these are the kind of numbers we're looking at. Like I said, over 10,000 of these individual facility descriptions. And, oh, that's interesting. Looks like an image is no longer in the slide. Just a second. Huh. Can you all see that? That's very strange. There's some empty boxes there. They were not empty earlier today. But I'll just go right up to the next one then, actually. So, we're going to break down a little bit of what's going on in this accordion. And first up at the very top, as I mentioned, you've got the most important content. Because the importance of this content and the desire for consistency to provide the consistent experience for veterans, this is all nationally managed stuff. So there's actually only 2 or 3 editors across all of VHA who can edit this content, and that's going to trickle down to the 10,000 individual descriptions. Secondly, you've got this very facility-specific, highly localized stuff, and we're actually going through an iteration of the content model here as we've kind of figured out how to improve the content model to support this data a little bit better and to improve the consistency of it. So it's got things like addresses, maps, phone numbers, information about appointments. This is the content that veterans need to know how to access their services. And for that, you've got about 2 or 3 editors per system, times 150 systems. But they're actually going to be working with a lot of people on the ground at each of these facilities to kind of collect this data and manage it and update it over time. And then finally, you've got this kind of blobby content at the bottom, and this might become less blobby over time, but for each of these, because of this regional flavor that health services can have at VA, there's, from the business perspective, and to some extent from users' perspective, it's really important for each healthcare system to be able to add their regional flavor to this content. So this is an opportunity for a whole healthcare system to have kind of consistent descriptions of what's regional about their service. So if you have 7 facilities, this content is going to be the same across all 7 facilities, whereas this content here will be different at each facility. But just to step back to the veterans experience, it's a seamless. They don't know that this is all happening backstage, right? This, for them, they just see this all as one set of seamless content. And that takes a lot to put into place. So, yeah, a little view into the backstage, and yeah, we're still using the 7 in Min theme. We have lots of ambition to bring in a Claro-based administration theme with some USWDS elements to it. And if anyone's interested in that problem space, I'd love to chat. But specifically for the governance, how we built in the governance here, we're using Workbench Access, which has been a really great, simple, but I think powerful enough solution for the enterprise. For people who aren't familiar with that, Workbench Access creates a kind of hierarchical approach to permissions as opposed to a role-based approach to permissions. So people are kind of at the bottom of the hierarchy can only edit the stuff that they've been added to, versus if you're at the kind of a higher part of the hierarchy in an organizational chart kind of way, you can edit anything below that. So you can see, well, maybe you can see because it's probably pretty small, but you've got the 3 main administrations here in the middle. So VHA here, editors kind of at the higher level of VHA would be able to edit these national health service taxonomy descriptions. Whereas if you're an editor at a medical system, you're a little bit further down in the facilities section. So yeah, so far this has been working pretty well. There's a couple of downsides to this approach, but I think it's the best option that we've come across, and it seems to be scaling well. And this is a little picture of what the healthcare taxonomy looks like. It's not pretty. Single source of truth does not necessarily have to be pretty, but it is portable, and that's important. It's available through VA's API clearinghouse called Lighthouse. As you can see in the screenshots, also there's a CSV if you're on the VA network. And there's a column on the right which just shows how many different VAMC facilities or VHA facilities are actually offering this service so far. So it gives a sense of what are the most common services and so on. So those numbers are going to go up very quickly in a short order as more facilities get moved into Drupal. Okay, so that's a little bit about the governance. Now I just want to talk about the editorial experience and back to the idea that we're doing editor-centered management for vet-centered content. And there's a few big challenges here for sure. So editorial experience has never been a huge priority for Drupal, as many people are probably aware. And I think complex content governance schemes make that even harder. It's really important, we feel, to explain to the editor what they can edit versus what they can't. All users of the CMS can see all of the content, they just can't edit it. And it's important for them to understand why and how the governance actually works. So that's something that we're working on and continue to try to improve. And then thirdly, when content is being pieced together in this kind of way to be seamless on the front end from multiple different kind of content types on the back end, how do you stitch that all together to help editors understand the kind of content flow? This problem is also exacerbated in a decoupled website like VA.gov, where we're not rendering all of this content within Drupal. So I want to talk a little bit more about that. The feedback loops when you're not rendering the content within Drupal are a little bit longer. And so, wow, another missing image. I'm going to just stop this presentation mode because this is kind of important. see if I can, oh, that is bizarre. It's missing from the slide deck as well. Okay, well, I was going to show a content proofing screen, and I'm not going to be able to do that. Parts of the slide didn't load.
Oh, that's bummer.
Huh. All right. Didn't do that on the dry run. So what you'll have to imagine is instead of showing the rendered front end of this content, we have an opportunity in Drupal to do something a little bit more than that, which is show other information on the what's essentially the node view screen, the node view tab that most people are on this call are probably familiar with. So content proofing is a term that came to us from Jeff Eaton, the content strategist, well, all around kind of digital strategist. But then we kind of riffed on that a little bit. So his point was that in a decoupled site, you can actually get pretty far in terms of rendering the content in a way that provides a good preview experience for editors, just with twig templates and so on. And we're also offering a separate front-end preview experience, but it doesn't work for all content right now. And this is a good example where you're kind of stitching together lots of different content in one place. So what we've done in the proofing experience, the node view page is added a bunch of metadata to the page to explain governance, to explain what content types are driving which part of that content, as well as some of the governance tools right in the node view. So you can see, for example, the revision history, some of the metadata associated with that page. Kind of it surfaces things like your page title and your meta description for SEO right in the node view, something that you can't do in a non-coupled site. So what kind of started as a big challenge for us with decoupled, we tried to turn into an opportunity for improving. We've also added a broken link viewer in the proofing experience so that people can catch whether or not they may have a broken link in their content. Now this is, I don't know, I don't know what to do here. I wonder if this is the rest of the deck is going to be like this. I'm just going to refresh my page. Oh, they're back. Look at that. Did you turn it off and on again?
Maybe you can just show from the preview, like if you back out of the presentation, just show it from that.
Oh, it's there now. I just have to refresh
okay, great.
The URL. So I don't know what I was missing before, but anyway, there's an example of our content proofing screen. And it's undergoing a pretty big design iteration right now. And then the next thing is dashboards. This is also something that's being added into the site just as we're about to bring in a whole bunch of new editors. So this is work in progress stuff, but what this part of the editorial experience is doing is kind of explaining the content model in an actionable way. So we've understood the top tasks of our editors. There's somewhat of a tension between the top tasks that are vet-centered versus the top tasks that are sort of organization or administration or like the business-centered ones. And so we've made some decisions within this design to sort of surface and privilege the more vet-centered content on the site. There still needs to be some of the other content as well, like the leadership page, for example. So this is, an introduction, if you will, to the content model without having to call it that, and it provides an entry point, a door into managing this content, including the health services content. So I'm not going to go into the subscreens here, but anyway, that's this is new, and our kind of hypothesis with this is that this is going to help editors understand the structure of this content so that they can manage it better. Okay, only got a couple minutes, shoot. So I'm going to zoom through this, but information architecture. As I think we mentioned before, we did card sorting and tree jack testing with over 800 vets. This was actually done by Jeff Barnes, who was with USDS at the time. He's now the deputy director of Depot, the Digital Experience Product Office at VA. They used to let him flex his UX research skills now and then. I'm not sure if they still let him do that, but anyway, he designed this research study around wayfinding, and quick before and after. This is the old desktop and the old mobile experience of the navigation. It really mixes together veteran-facing top tasks, but a lot of administration and stakeholder stuff, like compare your VA facility, and which was no longer really deemed a priority by vets. And this is kind of what we've ended up with. I've only got the desktop here, but we're really surfacing, especially on mobile, the health services and the facility links at the top of the navigation, and then the veterans' top tasks. So big emphasis on this is actually what the keynote today speaks to quite a bit. Like what are people trying to accomplish when they come to the site? And so big focus on top tasks. And there's 6 of them, but only 3 are surfaced here, and they're surfaced on a lot of the pages up near the top to help veterans accomplish whatever they're coming to the site for. Just want to note also, the whole goal is to get people into the facility. This is a bricks and mortar institution. The services are delivered on site. That may change, I guess, in some ways, but it is healthcare. So, getting people in has always been the priority, and that's where their service is going to be best. So a lot of this it's really about just getting people in the door, and the system will take care of them from there. Okay, so I think that'll pretty much wraps it up. We'll be posting the slide deck. We've got links to all of our research, the health services research, the taxonomy research, the research with vets, the research with editors that we've done, and then a few other links, including to the pilot website, to our repo, and to the content model. I also got a link here to Jane's a content model that she did that's kind of a universal healthcare content model. So if you work in this area, this is a great one to use. I think it's almost a roadmap for us for what things that we may add to our content model in the future, things like healthcare conditions and so on.
It looks like we have a question over here.
I think, Jason, we lost your audio, but
oh, there we go. Sorry, yeah, I think I muted it back. Was it completely automated? And then, well, there's other questions coming in. And in case, which tools have you used, and have you scraped all websites, or was it more of a selective manual process?
I can speak to some of the early content audits. So there were inventories that were done. If you do all of those 500 VA subdomains that we were talking about, that would break Screaming Frog, if you're familiar with that, because you kind of get to, because there are query string pages within, there's all sorts of things within. So we really didn't need to do an automation for kind of all of the VA facilities, because we weren't really we're looking more generally at what the structure was, what the required pages were, where we were sort of sensing patterns of duplicative content. But we did do an audit of all the VA, all the Pittsburgh VA pages. So there was an audit that was done in Screaming Frog, but then we manually, there was an inventory that was done in Screaming Frog, and then we did a manual audit of those pages. I think we're for Pittsburgh, it wasn't really that many. It was probably, I think, between 600 and 800 pages. And then we did a manual audit to map the original pages on the old site to the new site. We consolidated a lot of those. I don't recall how many, so Kevin, do you recall how many pages we went from the old to the new?
Yeah, there went from about 350 core pages down to about 40, and reduction in the number of words by 90%. The overall number of words on the site.
That's really amazing work.
Yeah, and then I'm seeing the top task methodology. So we've looked at that. So there was a slide toward the end that Kevin presented about the top tasks with 3 buttons. In terms of site structure, how long was, I am not aware of the length of the list of available tasks, in case that would be the UX folks that were involved in
Yeah, and we haven't done it with editors specifically. We've talked about doing it with editors. And one thing to note about all of this is that this is one product in the Drupal site out of about 8 or 9 products that Drupal manages. And sometimes we're caught between doing top tasks for all of our editors versus for just one of the product sets. And so we are likely to be doing more of both, but yeah, we haven't actually implemented a top task study, or we haven't performed a formal top task study with our editors as of yet. Great question. And I just want to add just the last question about, there's actually an entire team that's not our team that's responsible for translating all those A to Z pages into the new taxonomy. So they're going through, and it is a manual process, it's a highly qualitative one. And so there's actually a whole team of a different contract that's working on that right now for those 10,000, well, I guess 1,200 services.
Wow, really great presentation. I think the taxonomy portion alone on this is super valuable for a lot of people. I don't know if you guys have uploaded your presentation to Drupal GovCon's website yet, but feel free to do that if you can.
Yeah, we'll be doing that shortly.
Okay, great. Any other questions?
Well, Jason, I just want to say thanks so much for facilitating, and huge shout out to all the organizers of this conference. It's been so well put together, and yeah, so appreciate it.
Thank you both for speaking. We really appreciate it.
Got it. Thank you, everybody.
All right, thanks.
Good job.